Assalamu alaikum. Good evening, everyone. But I just want to check if all of you can hear me clearly or not. For those who can't hear, you can go to the chat and just put your concern over there. We will start at 8 o'clock sharp, but we're just waiting for more people to join us. Great. Okay, good evening, everyone. In order to finish on time, I think we need to start on time as well. As I mentioned before, if you have any concerns about the audio or any other concerns, you can always go to chat and put your concern over here. In the middle of the lecture, if you have any questions, you can always go to questions on your right, click on it and put your concerns, and I'll try in the middle of the lecture to answer them. Also, you will see on your right polls where in the middle of the lecture also I'll be asking you questions, so I'll be asking you also to answer through the from here as well. Again, as I mentioned, if you have any concerns, this is the time where you can raise your concerns through the chat about the audio or any other problems about seeing the presentation. First, let me introduce myself. My name is Shuruk Zakaria, Patient Safety Programs Manager at the Saudi Patient Safety Center. We decided today to talk about the handover process in all organizations. As you can see, that it's a very important topic, and we've seen that we have a lot of concerns coming from different hospitals about which tools we should use, how to check the compliance and so forth. And we decided that we can just put a quick lecture and in the same time to start communicating with people out there in other organizations. So if you have any questions, just let us know. At the beginning, let's talk about the definition itself. What does it mean? You will hear a lot of terms, by the way, so don't be confused or don't think it's another term. It's the same. You'll be hearing a handoff, sign out, or handover. They're all the same. You can see. They're all the same. We'll go through the handoff definition. Is the exchange of verbal and written information along with authority and responsibility between healthcare providers to accurately communicate pertinent up-to-date information regarding the patient's care, treatment, services, needs, as well as the patient's current condition and any recent or anticipated change. I've highlighted the important words for you: exchange of verbal and written. Because usually people think the handover is the verbal component only. We're talking about the verbal and the written, along with the authority and responsibility. So you're not just handing over the patient and thus you're not responsible for the patient. So you're handing over the responsibility as well. Another definition that you might come across, handover, is the transfer of professional responsibility and accountability for some or all aspects of care for a patient or a group of patients to another person or professional group on a temporary or permanent basis. So they're all common definitions for handover. As we mentioned before, we're talking about, so whenever you go and evaluate the process in your organization, this is one way to evaluate the handover processes in your own hospital. Look at the policy that you have or whatever program that you have and evaluate the verbal component, and you can check that part. Then look at the written component, and we're going to go through a lot of tools that can help you to evaluate the written component as well, and look at the transfer of professional responsibility and authority as well. So these three components must be covered fully in your policy or whatever program you have in place. Another thing that we notice that people do not look at handover as handover of shifts only. That's not it. We're talking about a big program over here. So you can divide your policies and look at, okay, what do we have in place? We're talking about two things here. We're talking about the extra hospital handoffs. When we're extra hospital handoffs, that's outside the hospital. When patient comes from outside the hospital to the hospital, inside your hospital, from the emergency to admission. And you're talking about the other way around, from your hospital to outside your organization, when you discharge and transfer the patient, let's say, to another organization. So that's also a handover that you have to take care of. What's the process of handing over patients when they get admitted and when they get discharged as well. In addition to what we know already, the shift changes, that's one, that's intra-hospital, that's inside your hospital. Another one is the service changes. Whenever the service change, even if the patient is still in the same unit, the service change, you need to hand over the patient. So if we transfer the care to another unit, also that's a time where you have to do a complete handover, and you need to have a process in place, clear to everyone. Not depending only on people telling you, yeah, it's done. Yeah, sometimes we know it's done between physicians, but we need to have something in like a guideline or a policy just to ensure that whoever comes in, even if it's a new employee, they'll be doing the same thing over and over. And the last part is the different specialty. Whenever the specialty change, even if it's inside the same unit, you need to have some sort of what's your process to ensure the handover is complete. And this is another point. We all know for sure that the handover is not something new when it comes to nursing. If you go and review the literature, you'll find a lot of references that will guide you when it comes to nurses handover, but really few. Only recently, you can find that the number of research and studies coming regarding to handover among physicians started to increase, but previously it was really difficult to find a tool. Okay, for people who just join us, just please check the audio. If you have any problems, you can always put it in the chat, and we will continue with the lecture. Now, another way to evaluate your current processes, whatever policy you have in place, go and check if you have answers to all these questions over here. Who should be involved in the process? Because you're talking about different processes, not only one policy in your all your hospital. Of course, you're talking about handing over among physicians, handing over among nurses and other healthcare providers as well. So be specific, be clear from the beginning. Okay, first I'm looking at the handover process among physicians. Which area? When? should it take place? And this is one of the problems we're facing, by the way. You'll find a lot of people, one of the challenges of doing the handover is there is no allocated time. They did not agree from the beginning about the time of handover. So this needs to be clear, and we're going to explain to you how you can do that throughout this lecture. Where should it occur? Another issue. Not a lot of people giving it enough attention where you can do the handover. Even though it's just handover, it needs to be done properly. The location itself needs to be good enough to handle everybody inside the meeting. The lighting, you have to take care of it. The level of noise, you have to take care of that. And the location, is it near the patient area or not? And if that's going to affect or not as well, have to be addressed. Okay. How should it happen? The process itself, we're going to go through it throughout this lecture of how exactly you're going to do the handover, what should be handed over, what should not be handed over, and the what needs to be handed over, as I mentioned. I have a question for you. I put a question for you under the poll. Just wait a second. You will all see a question, so I want to send you a question and I want you all to answer it as well. If you all see the question, please just let me know. We just added a question for you. Just on your right, you will see under polls a question. The question is handover a requirement under JCI, the Joint Commission International, and SIBAHI? So the accreditation bodies in our country, SIBAHI, is it a requirement or not? So I'll give you 1 or 2 minutes just to answer this question. I see some of you already answered. I want all of you please to answer it. Okay, so far all of the question right? Yes, the handover is a standard under Joint Commission International and CIBAHI as well. I will go very quickly over the standard because that's not the scope over right now, but I will what I need to do later on is to explain to you why is it so important for CIBAHI and the Joint Commission. So yes, under the Joint Commission, you can find it under the IPSG, International Patient Safety Goals 2.2. It's goal number 2, improve effective communication. Again, the key word is communication, and you'll find this everywhere. Standard International Patient Safety Goal 2.2, the hospital development implements a process for handover communication. And they very specifically tells you exactly the handover of patient care within a hospital occur between healthcare providers, such as between physicians. And this was one of the few times where they started with physicians. Usually we can see them starting with nurses and other healthcare providers, but they knew that one of the weak points in healthcare is the communication among physicians, so they added that as well. And you can also see that they added when this need to be done, the handover, shift changes between different levels of care and from inpatient units to diagnostic or other treatment departments. So when you develop your process, you need to make sure that you cover the handover among these 3 levels. And this is very important for CIBAHI and also for the Joint Commission. When you standardize or when you put a policy in place, the handover is not about having a tool or a form. No, you have to look at these 3 elements. First, you have to standardize the critical content of communication. So yes, let's say that you develop the form, which is the second part, standardization of forms and tools, which is common. We found a lot of hospitals where they have the form. But okay, what's covered in this form? What are the critical content that must be handed over to your colleague before you leave the hospital? That's what's missing most of the time, and I'll be showing you example forms. The last one is data from handover communications are tracked and used to improve approaches, which is, again, we cannot find it in a lot of hospitals. Some don't know how to do it, and some only depend on the incidents. Only if there is an incident, it will be reported, but no other forms of evaluation is used. CIBAHI alone have about 19. I picked up 19. I don't know, maybe you can pick up more. I picked up 19 standard. 19 standard and talking about having handover, whether it's about under PC standard or under any other standard for CIBAHI, for quality management, OR. They focus also on critical care, as you can see, and they're all asking about the same thing. The ICU, the PICU, all these are the summary of where I can find the word handover must be there. In ICU and ER, in ICU again, several times, about 19. CCU, all of them. So why all this sudden attention to the handover? What they did, which is something that also the Saudi Patient Safety Center is planning to do on a national level, is they looked back at all the incidents, the sentinel events, and they tried to look at the root causes of the problems. And majority, as you can see here on this slide, since that time until now, it's communication. And when you go and drill down on communication failures and where did it happen and which locations, you'll find that yes, the handover was part of it. This is one of the oldest evidence of developing handover protocols. This is from the Joint Commission back in 2006. You can use it as a reference, but I can also give you another reference that you can use if you want to read more about handover of patients. Go to Patient Safety Net. I always advise people to subscribe to it because it will always give you a lot of updates, articles, but also you can search through their web to all articles related to handover, patient handover among physicians, patient handover among nurses, and they can pull out for you all the studies that came regarding your topic. What will happen if we don't do proper handover? If we don't do proper handover, what will happen? These are points of potential failure. Neglected, missed information. Yes, we will miss a lot of information if the handover was not properly done. Unclear transfer of responsibility. Team unaware of transfer issues. Patient and family unaware, and that's a big thing here because I know it's a challenge in Saudi because until now we're not really getting patients involved in a lot of things. So this is one of it, the handover Ask yourself when you evaluate your process, to what extent are you involving the patients and the family? Was it done? Were they involved or not? Is your organization ready to involve them in the process right now? If not, that doesn't mean you stop. It means that you will start educating people that it will be coming soon. So if they're not ready this year, maybe they're ready next year and so forth. Change in status, patient status can change and people are not aware. That's one of the disadvantages. Lack of mechanism for question and answer, which is one of the advantages of having handover, is people can get a chance to ask questions. What I want you to get out of this lecture with is to change your mentality, the way you look at the handover, to team approach, from personal continuity to system continuity. You have to understand that, yes, a lot of people are working during working hours, but what happens during night shifts? There's only one. What are you doing to make sure that that one person knows everything that happened during the day? For the handover benefits, I'll be talking about the benefits for the patients and for the healthcare providers. For patients, we know already, safety is protected, greater continuity of care, decreased repetition. Decreased repetition, for those who didn't get it, is imagine a patient in his room seeing a physician for the first time. Then the next shift, he will see another physician who will be asking the same questions again, or not knowing about something that he mentioned to the previous physician. To him, that doesn't really show the continuity of care, which will lead to another thing, the last point, decrease in satisfaction if it wasn't done properly. So focus on number 3 and 4, because usually we don't look at these points. If you want really to decrease repetition and increase service satisfaction for the patients, make sure the handover is done properly. The good handover for the benefits for the professionals, for us, number 1, of course, is the professional protection. Go back and review your Sentinel events. You'll find that in at least a few of them where handover played a part. And you will find people saying that, yes, the handover played a part, but there was no documentation of it. And if there is no documentation, of course, if it's not documented, it's not done. And of course, this will lead to a lot of litigation problems. Reduction of stress, because people will be up to date, know everything. So of course, you'll be less stressful, knowing that everything will be fine when you leave the hospital, let's say, because your colleague knows everything about the case. And even if you just came from vacation and or from another shift, you'll make sure if the handover was done properly, you know you can handle it in your area. Another point is educational, because remember, the handover is not always one-to-one. Sometimes it's open for the whole department. So junior staff can be involved as well. So that's sort of education to all of them. Job satisfaction, everybody will be highly satisfied. And the additional point, this is also important, and that's why I thought I better share it with you. Doctors to seek second opinion. Sometimes it's not easy for physicians to seek second opinion. So this is an opportunity for them. When you hand over the case to your colleague, a lot of people will be attending. If it's done in a meeting, it will be a good chance for them to discuss the case and get second opinions, if not more. Junior doctors to seek supervision, because that's where they will get the supervision as well. Doctors to debrief. And I know that not a lot of people do that, so it depends on your organization. So one way to look at if debriefing was done in your organization or not, go and check the process of handover in your hospital. Reminders to be given to follow up results, which is extremely important, because that's for patient safety now. Most of them are focusing on missed results. So, or people not following up on results. So that's a good timing where they can remind themselves and their colleagues about the pending follow-up results. The early referral of patients to other disciplines. That's because of the discussion, they might pick up on cases that need to be referred earlier. Few points for you to consider to ensure that the handover process is done properly. Sometimes you just have a process in place. This is your role. If you're working under quality management or patient safety, make sure when you do the education to teach the people, because sometimes because they're busy, they will forget. Just remind them that please make sure that whenever you do the handover, it needs to be done in a place where there are no interruptions in any sort. Nurses interrupting the physicians while doing the handover, or phone calls, or pagers, or patients. It can be anything. The background noises. So it cannot be done, for example, in the middle of the unit. Other distractions from unit activities must be limited as much as possible, of course. The handoffs require a process for verification. So teach the physicians, teach the nurses that yes, it's a handover process, not one way only communication. Once you're done from a certain point, as you can say to your colleague, can you please repeat back just to make sure that your colleague understood what you said. The receiver of the handover must have an opportunity to review and ask questions as well. Must include an opportunity to ask questions, as I mentioned. And the last point is the handoff must be structured, standardized, and that's something I will be explaining in the following slides. Okay? I'll be asking you now another question. I want to know, let's see. I'll be putting a question for you. Question is, do you have in your hospital a standardized tool? Are you using a form or not? Do you have a standardized tool in your organization? And the answer will be yes or no. Again, from the same place, under pause on your right top, you find the question, just answer it. I want to see the results. You can start from now. Okay. Okay. Oops. You found people answering no. Okay, that's good, because it means that somebody will learn from this lecture today. Okay. I want more people to answer. Some people are still not answering. Ladies, I want you to answer under the polls, not in the chat. The chat is not only for the technical problems. Okay. So majority, I found only a few who said no. Majority said yes, they do have a process in place. We'll continue with the lecture because I want you to learn how to evaluate your tools. And once you learn, you have to go back with the teams available in your hospital, work together. You're not going to do it alone, making your process even better, if needed, of course. So the question is, what's your typical handoff practice? This is a question for the physicians in your hospital and the nurses. Is it hit and run quickly? Just this is exactly what I need to do and quickly run, or is it done properly all the time? Now, the question that I get all the time, what tool should I use? Is it one tool? Are these the tools that you want me to use or not? The tools that I'll be showing you now are the critical content, not the form itself. The content, yes, you're going to do the handover. I'm going to hand over my patient to my colleague. Okay, what technique are you going to use? Or as I'm going to show you here, we have about 8 of them. Sign out. And each letter represents something. I pass. This is the easiest one, and I found a lot of people like it even better. So I pass, and just simply they have to remember I pass, I, illness severity, P, patient summary, A, action list, S situation, S census, and so forth. There's the 5 Ps. This is the third tool. Number 4, I pass the button tool, and each one of them, as you can see, have a meaning. So it depends on you. You don't choose on the team's behalf. Don't do that mistake. You need to make them feel that they are involved and they're making decisions. So in order to do that, of course, you'll be developing a team, and that team, depending on your goal, nurses, physicians, they'll be choosing the tool that they prefer as a team. So this is one tool. I pass the button. Anticipate. Another sort of SBAR, similar to SBAR. IMOTA or IMOTA tool, another one. And this is the updated approach. The SBAR approach, of course, I'm not going to forget that. So you can see like a total of 9. So again, don't choose on anybody's behalf. Let them choose the tool that they prefer. And you can always put it on a stand or something and share it with them just to remind them. Put it where they most of the time do the handover, just to remind them to do the handover properly. But again, this is not the form. Let's go back again to what's missing in the current handover process. The critical items, the safeguards, are we using a checklist or not? The current clinical status covered or not? The patient and family involvement, the nurse's involvement, is the process, does it cover a chance for me, the recipients, to put any questions if they have any? One of the questions, I'll be covering, of course, all the answers. One of the questions people ask is, are we going to hand over every single patient? Sure, this is not practical. We're not going to do it. Of course not. When you do the handover, you have to ask a set of questions to make sure the handover is done for those people. Because the handover doesn't mean you repeat everything. Everything is in the file already. But we need to make sure that those people who are critical, unstable, those people who have pending results are really handed over properly to your colleague. Just ask a simple question. Usually we ask physicians and nurses, ask a simple question. What do I want my colleague to know? Something really urgent before I leave about this patient, if any. So ask yourself, is the patient physically moving? Is the patient critical or unstable? Is the handoff temporary or permanent? Is this the first time the receiver is hearing about this patient or not? If yes to any, it means this is there is an increased risk, which means handover is this is another tool, very well-known tool for emergency departments. This is another tool, as you can see, I've highlighted for you. Again, this is just a sample. You can use it as is, or you can do modifications. Compare it to the handover forms that we see among physicians. Physicians sometimes tell you, yeah, we're doing handover. Look at their forms. You'll find patient name, age, problem list, key issues, and the receiving party, and so forth. But it doesn't cover the highlighted areas, as I mentioned here. Potential safety issues or precautions, pending items, who rounded on patient, so the patient was involved or not. Was the handover, was it communicated to the nurse or not? So these are the elements that we always find it missing in the handover. So go and check and advise your colleagues that, yes, we know you're doing the handover, but are you making sure you cover the critical component? That's what we want. This is the same form, but this is the back side. Remember, I told you it's not only about a form. You can also have a tool to help the staff remember. So some of them use the SBAR, some of them this one. They use something they call the 5 R's. Record, patient critical details, follow up, review the form and the computer chart, round together, relay to the team, receive feedback. So again, they prefer this acronym. You can use another acronym. You can use the SBAR, you can use the IPASS, you can use whatever the team decide on, not you alone again. This is another form where you can see it's different than the forms we see among physicians when they do the handover, if they did it, if they did the written component, I mean. You'll see that something missing here is the reason for the handover and the outstanding issues. So do your current forms have these 2 parts or not? Another sample form that tells you what's missing. Any action required after handover. Anything that you need to tell me before you leave the hospital, and by whom. Very specific. For hospitals who have or going to implement the handover online or using the electronic system if they have any, make sure that again a team is behind that. Do not do it alone. Make sure that you discuss the critical component, what's need to be there. Of course, the responsible physician is there. You'll be facing a lot of limitations, that's for sure. That's why if you're moving, move gradual. And of course, just like any other project, you have to test it, pilot it before implementation. Testing will help you to be in more control rather than just apply it hospital-wide. For the emergency, okay, 1 second. I'll go back again because I had one question about the emergency tool. The emergency, you'll be finding that you'll see that a lot of people argue in the emergency department in your hospital that the process, which is excellent point, because sometimes they will argue with you that our process is different. We cannot use the same tool used in the inpatient, which is right. It's not wrong. And that's why, yes, we want standardization. We want to be a high reliable organization, but in the same time, we have to be flexible because in healthcare, it's very complex. You cannot have 100% standardization everything. So in the emergency department, this is what they do. This is just a form where you can see here, they put the patient name and age, if they want to hand over this patient. They put the problem list and key issues. And here they will put the patient safety issues. If there is any patient safety concerns or precautions under pending issues, you have to tell your colleague if there is any pending test results, for example, or something because of time you were not able to complete, so it's still pending and you want to do it for this patient. And here you'll be doing it around, as I mentioned, about involvement of patient. In the US, in UK and other countries, they involve the patient in the handover process. So it's done inside the patient room with the patient. In a lot of hospitals in Saudi, we're not there yet. If you can do that, you can be one of the pioneers, and please share your experience with us at the Saudi Patient Safety Center. And the last point is the communication with nurse. When we review our incidents, you can do the same thing with your incidents. You'll be finding that a lot of times saying, yes, I did hand over this to my colleague, and the nurse will come jumping in saying that, but I was not informed if there's a change or even pending results. So that's why they're encouraging you here using this form to communicate properly with the nurse. I hope I explained it good, but you can always go online, by the way. This form is from, you can see the reference here at the bottom, Emergency Medicine Patient Safety Foundation. You can find it available online for free, and you can read more about the tool and how to use it, how they used it, if there is any other information. All the other tools, by the way, I'm going to share the presentation handouts with you later on. You can always have the time to go Google them, whatever tool you didn't get enough information about, and you can find them online with all the details that you need. Okay. For those who are going to do the online reporting handover tool, as I mentioned, testing is very important, making sure that the team is done properly, multidisciplinary team. It covers all the area under the scope, and in the same time, you need to make sure, of course, you cover the IPSG goals, like making sure that the patient name is there, the age, the MRN is there, always 2 identifiers. And of course, you have to, if you can do FMEA also before the implementation, just to make sure that you cover all the failure modes, what can go wrong before the actual implementation. A word of caution on TIC, IT solutions alone cannot substitute for a successful communication act. So if you don't have a process clear for everybody before you put a tool, it will not be successful. That's why you have to make sure that you flowchart the process before implementation, before moving online. Just make sure that everybody will do it with you together as a team. Now you got the background, the theory part, as I can say, and now if you want to apply it, as I mentioned before, you need to have a PI project, performance improvement project, or if you want to call it rapid cycle improvement, whatever you want to call it. Just remember, the goal is to have a multidisciplinary team and to involve the right key members, the owners of the process. You cannot develop a process of someone on behalf of someone. And make sure that you engage the physicians and as physician champions. One thing that I always tell people about is to bring physician champions. Or if it's a nursing tool, bring nurses champions and so forth. What the goal is, sometimes people don't listen to you and you find it very difficult to implement. So what you can do is, if you know somebody who's not a leader, not necessarily a leader by position, but people love that position or love that nurse and they listen to them. So if you know a person like that in your hospital, bring them with you in the team. Educate your physician and nurses. And this is something very important. A lot of people in a lot of hospitals, we find that they have a lot of people have tools or policies in place, well written, but the actual implementation staff are not even aware of the policy. Or they may be aware of the existence of the policy, but they're not educated. So this is not only applicable to this lecture for the handover, but you have to make sure that always, whenever there is a new process in place where you come up with a guideline or a policy, that it needs to be followed by education. Make sure that the people who will be doing the handover, who will be applying that policy that you just came up with, are really educated on how to do it. So they will get the chance to share their concerns. So it will be not only one way, it will be two-way benefits. So they can also share with you the concerns or the limitations, the current limitations in the tool, which will help you in continuously improving the tool. Listen, support, reassure, use a professionally designated handover form. We talked about that already. Again, I just showed you examples, by the way. If you go and check, you'll find a lot of hospitals did it in different ways, which means you can develop your own. Now you get the basic, and you can, as a team, decide of what you think is critical that needs to be handed over, and as a team decide and go ahead. Launch as a team-based approach, as I mentioned, monitor the process and give feedback. That's what I will be focusing on right now, is the feedback process. How do you evaluate and share your success? The last part is, most of the time we forget to do it, whether it's lean or any other tool. They always, if you want the people, especially if you're working in quality and patient safety, if you want the people to continue working with you, you have to share your success. You have to go back to your team again and just say a simple thank you, or just use any tool. Bring a cup of coffee, pizza, whatever you prefer. Sharing the success is by sharing whatever you reach, positives and negatives, with the rest of the hospital. And if you dare to share that with other organizations through research, that will be excellent. And I think one of the limitations, if you look at now at the zero harm campaigns, one of the things they're focusing on is focusing on research in patient safety. Physicians, nurses, they all do a lot of PI project, performance improvement project, but they don't look at it as something worth publishing. Change that mentality in your hospital by encouraging them to share their success, whether through a website, your own website, intranet, I mean through your department's newsletter. You can share it with the public, you can publish it, whatever you want. Or I can add to you something new right now. You can share it with the Saudi Patient Safety Center, where we can also teach it, because we continuously teach people about the patient safety officers, I mean. We're putting a lot of slides for research done elsewhere. I think it's time to move and just put something that's done nationally in my country. If somebody can share with us their success, that would be really great. Okay, the question that I'll be asking now, that will be the last question for you today. Again, I'll be using the same approach. Before I answer some of the questions, I'll just put the question here, and I'll go back again to the questions that was asked. Question is, do you have a process to evaluate in your hospital? Do you have a process to evaluate the handover process in your hospital? Do you have a policy? Do you have a form? Yes or no? I know what I noticed that some people will say, yeah, we do have a process to evaluate the handover, and most of the time, okay, how do you do it? They depend on the incidents only. If something happened related to handover, I will consider this as an indicator for me, but that's not an evaluation tool. I'll be showing you it again. Even the literature, if you go and check, you'll find also little research about the evaluation tools. If you have any different approach than what I will mention, please share it with us so I can share it with the team. Okay, not a lot of people answered. I want more people to answer. Do you have a process to evaluate the handover in your hospital? Okay. One of the questions some of you asked, so can we have different sign-out forms for different departments according to their responsibilities? Well, it's not advisable to have more than one approach, but again, that's something we faced only with physicians. For nurses, usually they have only one form, but of course not inside the units, one form. Transfer of care, that will be something different, of course. Or with procedural areas, you can have something different. But when we're talking about in the units among healthcare providers, usually we prefer to have one. But from my experience, I've seen that emergency, they'll be talking about their process is different, so they might want to have a separate form, especially if it's online, not a simple form. If you go back to the flow, if it's only on a form, not something online, and they're not affected by the process, they will have to continue using your own form. If there are limitations and they were very clearly articulated from the beginning, these are the problems that we'll be facing, therefore we need to have our own. The decision will not be done by quality management alone, that will be done through the patient safety committee, the medical office, the chief medical office. They have to decide together. The decision have to come from them. We don't want them to say later on quality said so. We believe in standardization as much as possible, but we need to be flexible sometimes to accommodate people's needs, if it makes sense, of course. So again, as I mentioned, standardization is the key. So yes, we need to have one. Unless there are limitations to having one, then it needs to be addressed in a higher level. Patient safety committee, just raise it up to the hospital administration, so they will make the decision and come back to you. Okay, so what tools shall we use? Some departments, and again, there are different approaches, will assign someone to review the handover process. So they can come up with an evaluation form to evaluate the organization, efficiency, the communication skills of the person who's doing the handover. So it's by person. For example, they'll be giving me a form and they will say, by the end of this week, for example, or end of the month, evaluate Ms. Shuruk, how is she doing the handover to you? So you will be evaluating 4 components: the organization, efficiency, communication skills, clinical judgment, and professionalism. Again, this is just examples. You might have even better tools than this. This is again peer evaluation, and this is how they do the evaluation. This is one way. Some people will assign one person to evaluate and go back and review it one by one, like random sample every time, and review it if it's written. They keep the documents and they go through it and see the way it's written. And usually it's the person, let's say, especially if they focus on the residents, so they'll be assigned the person who's responsible for the residents, for example, who will do that. If you have an online form, that's something very important to, from the beginning, you have to remember that when you develop the form, make sure that you tell the IT, these points I need to make sure that I can retrieve it later on, because this is how I'll be evaluating the tool. So decide from the beginning. Okay. If I missed any questions, I'll try to answer it after the lecture, but I'm trying to accommodate as much as possible. Okay. So this is the peer evaluation, as I mentioned. So what we need to evaluate is we need to examine the written handover sheet, or by direct observation. If it's done in a meeting, during that meeting, somebody will be in charge of observing the handover technique and evaluating on the spot. If there is any audio or video recordings, can be done. Use checklist of pieces of information most common, yes. The evaluation forms, for example, the one that I showed you. Measure items related to clinical reasoning. Analyze patterns of communication, interview clinicians. There are different ways of doing it. Some people are only depending on feedback from incidents. So if there is any incident related to handover, this is the only way we're checking if there's the handover is done properly or not, which is not enough. We need to have more ways to evaluate it. I found these two tools also to evaluate the electronic tools. I know that some of you have electronic forms, some of you don't. For those who are having or planning to have, make sure that you go through these two lists. These are simple questions you have to ask, and the answers will guide you to evaluate the tool as a team. The same. Monitoring and evaluation, an audit or review of the process, staff participation. So what are you going to audit? You'll be reviewing the staff participation. Are they all participating or not? Attendance. Are they all attending the meetings? If it's done in meetings, some departments, I know they are mandating the attendance. So are you doing that or not? Is it time for you to mandate the attendance? Who's making sure that they're following up on those who are not attending? What kind of action they should take against those individuals? Yes, I'm with the just culture, but you have to understand that we need to increase the level of accountability among our healthcare providers. Use of checklist, as I mentioned, completeness of documentation. So you can, those who will go and review the written components, they'll be looking at the completeness of documentation. If they're missing the important fields most of the time, like remember one of the forms I showed you, it shows pending issues. If it's missed blank, I don't know, blank because you missed completing that section or because it's not applicable or what. So not leaving it blank is not acceptable, for example. So this is one way to evaluate the completeness of documentation, the duration of the session. Are you exceeding the time? You're not supposed to take a lot of time. You have to control the time you do the handover. If you exceed the time, that will not really encourage people to attend the handover session, especially among physicians. And of the role of handover in any local adverse events addressed, go back and check your incidents. If any related to handover, go and do a root cause analysis, trying to understand how did the handover contribute to this event and if there is something that you can do to prevent it from happening again. Feedback from participants through structured interview. You can do interviews one by one. If you're worried that they will not share their concerns, you can do it one by one interview, very short interview, asking people about what you think about the new tool that we implemented. How do you think it's done? Do you have any ideas for improvement? And do not bring people with their superiors in the same room and expect them to talk. If you bring residents, do not bring the seniors with them. Just play it smart so people will feel more free to talk and tell you exactly how you can improve the tool. Assessment of impact on efficiency, length of stay. I don't know if you can, how you would like to do that, but I know a lot of people who like to correlate results. I want to correlate the number of events related to handover to the length of stay, or to the staff or patient satisfaction, or to the OVRs, whatever. You can choose and try to study the relationship between these two. Again, you do that as a team. Maintaining, rewarding, and disseminating information about improvements. Rewarding. Do you have a rewarding system in the hospital? If any, you can use that to reward the people who are doing the handover right in your area. You can collaborate with quality management department. You can put a program in place, or you can simply do it in your own area, in your own unit. Dissemination of information about improvement. As I mentioned before, just make sure that when you do the handover, when you do the sharing of successes, just you cover everything. You cover the positives and you cover the limitations or the challenges that you have faced. It will also help people in other areas to learn from your challenges. Maybe they can come up with other solutions and help you as well. I know people until now, when we share the lessons learned from incidents through newsletter or safety alerts, yes, we do keep confidentiality, but sometimes people will know that that incident happened in radiology, let's say. There's only one radiology department. So you might find them being defensive or not ready yet. That doesn't mean you stop from doing it. You just need to let them know that you are, in order to be in a safety culture, you need to have an organizational, a learning organizational culture. In order to do that, we have to share the lessons learned. More recommendations for good standardized clinical handover. Needs to be embedded in a hospital policy. So you need to have a policy in place, very clearly written, addressed with the owners. Involve training. Training is a must. Do not just put a policy and post it. You need to make sure that the staff are trained on how to do it properly, and the training must be ongoing. Be tailored to local unit needs. Remember, for those who ask me, can we have more than one? The tool, you can have one tool, but it covers the needs of all the units. So in order to avoid having different forms, make sure that when you have a team, let's say that you're just in the beginning, make sure you cover all the areas. Don't come up with a tool and at the end you'll find emergency having different needs at the end, ending up having, okay, have your own form, emergency department, because you did not involve them from the beginning. So make sure your team is multidisciplinary from the beginning. You cover all the areas we'll be doing handover. Be recognized as a multidisciplinary team. It's a team activity, as I mentioned before. Command designated time and location. The policy have to mention very clearly what is the exact time they'll be doing the handover and the location. Especially for physicians, you need to be a designated time, and it's not the round time. Or so avoid the time that it's not possible even to do the handover. And the location have to be also allocated and very clear to everyone. Determine clear arrangements for ongoing care of patients, because that's the goal after all. And define who must be present, including senior consultant and staff. So the handover must be clearly, the policy itself must be clearly saying who will be present during that meeting, if any. And at the end, I'll be sharing with you the challenges to continuity of information, the challenges with the handover. And you can also share with me if you have more. Lack of dedicated time to complete patient notes and participate in handover. Yes, we found a lot of people complaining not having the time. Personal style. Lack of structure and formality. Lack of structure and formality, where personal style, yes, you can see it. Again, if you're doing the evaluation and if you're asking staff about their feedback, you will see if we have any problem with some of the staff or not. That's why you always have to evaluate. As a quality professional or patient safety, you can do that even through your lectures. Let's say you're giving a lecture in the auditorium, give it a space for questions, and you'll find people who will be asking, sharing with you their concerns, and they might tell you about things you don't know about. Lack of effective information management technology. Some don't have that privilege. If that's the case, just make sure that you cover everything. For those who don't have IT solutions, they might have a problem with one piece of information on that chart. The old chart might not be there. So also, if you're doing the handover, not everything is in front of you. So you're just simply going to skip and you will tell your colleague, just go and check that information on that if it's another system, let's say. Increased numbers of patients under the care of a single team. That will really will not really encourage the staff to do proper handover, so it needs to be addressed. Frequency with which lead consultant changes, frequent movement of patients between wards and departments, sometimes without the doctor's knowledge. And I do remember certain cases where we faced the same scenario, where physicians are not aware. Yes, the patient moved to another ward, another service, and the primary physician was not informed. So you need to look at the causes of those issues and fix it. Involvement of multiple. If you have incidents, by the way, you can go back to your incidents and look at the root causes. If you don't have incidents and you don't know where to start, you can do an FMEA project. Involve the people in every area and ask them, what do you think can go wrong here? And they will tell you. Involvement of multiple specialist teams can really increase the problem. Transfer to other healthcare professionals in the community or other institutions. That will also be a challenge to some organizations. For the forms, I tried to summarize some of the forms I found. Here's 10. You might have more than this. As I mentioned, the patient safety net is a good source. Even Google is a good source. If you just Google handover tools, you'll find a lot. But I'm trying to be scientific, so I'm sharing with you the patient safety net. This is another source that I use for today, but it has a huge amount of information. You can always use it. Safe handover, safe patients. And I think that's it. Really what we thought is just to give you a guidance. So this is the lecture and some of the tools, and we focus on the limitations. Like, I know the deficiency in standardization among the hospital. How do you evaluate the current process? I try to collect some of the information just to make sure that you have the basics with you. And if you want to share with us your concerns later on, feel free. We're always there for you. If you have any questions just before we end up the session, this is the time. And I'm going to read some of the questions here if I can answer them. Okay, one of the questions say there are issues for endorsement at critical care on which written endorsement will be difficult, especially during duty hours with few number of physicians. How can we improve the compliance for handover at critical areas? Well, first of all, I advise you to read. We don't want to start from scratch or reinvent the wheel. Sometimes you'll be shocked that other organizations face the same problem and came up with solutions. So that will save a lot of your time. So number one, go and read, do the basic homework is reading, and then develop a team and try to come up with solutions. Try to understand also a good point here. In critical care, a lot of issues, I don't want to say not applicable, but there are certain ways of handling it, similar to applying time out in critical care. Critical care, it's considered like an emergency situation, so of course the handover will not be done in the same way. Okay. How can we improve the compliance rate of communication other than using SBAR? How can we improve the compliance rate of communication? Compliance rate in using the tool itself, Using the tool, it's different. So if you're using online handover tool, you can always work with the IT department trying to check the compliance, even by department. They can pull out the report for you on a monthly basis, and somebody from that department can work on the analysis part. And you can decide how you will calculate the rate. Other than using the SBAR form, we talked about different forms, so I hope that I understood your question right. We talked about different ways of improving the communication. You can use the SBAR, you can use any of the other tools that we presented. Okay. Okay, is the doctor's morning meeting will be enough because we face resistance from them? We face the same issue. Morning meeting, if they're covering all the points that we talked about, they need to understand three things. I remember the first thing we told them, handover is not the verbal component alone. Where is the written component? If they showed you the written component, then the question is, are you covering the critical component that's needed from the Joint Commission and from CBAHI? If they showed you that part, then okay. If not, then it's of course not. Then you just try to improve it to cover all the points that we mentioned, is who's attending those meetings, who's tracking, who's evaluating, what if there is a policy or not, because you'll be shocked that there is no policy. So if there is no policy, how do you cover weekends? How do you make sure that these things are not missed during those times? So just ask those questions and walk with them step by step. And of course, the change will not happen just over time. One thing that can help you, before you start applying a new project, get the okay from the higher management. So this is a medical department, so the medical administration, put a plan with them. Usually we present in their meeting and we tell them exactly what the JCIA wants, what the literature say, what the best practice say. Forget about the accreditation body. What patients say, why is it so important for patient safety? And when you get them involved, they will ask you, okay, what do you want? Okay, well, this is what we need. They might open your eyes to challenges from the beginning. So that will be really helpful before you go to the unit. So when you go to the unit, it will make your job much easier, because they will be easier for you to meet with them, because you got the green light from up, and easier for you to apply it because you already worked with the administration on the fact that you want to standardize. What about transferring patients to other facilities? When you transfer patients to other facilities, make sure that your job here is to protect the patient and to protect yourself. Because what happens is, we've heard different scenarios where people will say, this patient came from that hospital, without mentioning names, and they did not, for example, mention that point to us about this patient. So how do you prove that, no, you did your part and you did hand over that piece of information to them? That's why we advise hospitals to have a form when the patient is transferred to another organization. That form cover everything needed to protect. Think about it this way. How can I protect my hospital from any problems that can happen to that patient outside? You don't want people to come back to you and say, you failed in doing this or that. And I remember I was involved in several cases where people will say that we did hand over that part, but there was no documentation. So make sure that there's a documentation in place to protect your staff, nurses, physicians, before the patient is completely handed over to other organizations. Okay, let's see, more questions coming. You don't want me to end? Handover is a must to avoid wrong information. Okay, multidisciplinary. Handover is a must to avoid. Multidisciplinary handover. it's the ideal to have a multidisciplinary handover. When we say multidisciplinary, meaning having the whole team together in the unit, that's among physicians very common. Yes, because they do usually the meetings, but sometimes we do one-to-one handover. For nurses, sometimes it's one-to-one handover. Even for physicians, sometimes from different departments, they do one-to-one handover, especially shift changes. But what's needed, I wanted to mention one important point. Yeah, one of the points that usually people ask whether is to have a face-to-face or over the phone. Face-to-face is the very advisable, and usually all the references I've read, they're encouraging face-to-face. But that doesn't mean if the face-to-face is not possible, the handover will be missed. No, that will consider that like an emergency. And again, what specifies that is your policy, whether you want face-to-face or not. But again, remember, if you put face-to-face, it means that the surveyors or whoever will be evaluating you against your own policy. In Saudi, we have both JCIA and SIBAHI standards, and both the hospitals have different tools. How we can transfer patients from one SIBAHI accreditation hospital to JCIA. Well, the Joint Commission do not specify tools. No, they want you to standardize your process. As I mentioned, there is one slide that shows, yes, you have to standardize your process. You have to standardize the tools and data for evaluation. SIBAHI, on the other hand, they're very thorough. They ask you to exactly where, which area, what kind of handover, but they do not contradict each other. Both do not contradict each other. And usually we go with the stricter. So if the JCIA is very general and SIBAHI is very thorough, you'll be going with SIBAHI. And SIBAHI is the national, so of course I'll be with SIBAHI, trying to just make sure that, because they do understand based on the sentinel events in Saudi, they know which areas that they have to focus on. Okay, yeah, the ideal, as we mentioned, the handover be done face-to-face in the presence of the patient, but be careful of what you put in the policy because you'll be evaluated against that. If it's not in, because sometimes we talk about a lot of best practices, right? But it's not a requirement from Joint Commission or SIBAHI. So just make sure that you don't put a lot on the staff, and because that's how the surveyors will be evaluating you at the end. So if SIBAHI, let's say, mentioned it needs to be face-to-face, then yes, go ahead, face-to-face. If not, it will be a decision by the organization. And remember, if you put face-to-face, then you evaluate yourself. People evaluate you against your policies. Working in polyclinic, is it the same policy in referring patients to hospital? Thank you. For people who are working in different settings, first thing you have to do is to evaluate your current processes. When do we hand over patients? Do you hand over patients to other organizations? Do you hand over patients to your colleague? If that's the case, yes, you need to have a policy, whatever policy, and you decide together. I think it's less complicated in the polyclinic. You just need to have to decide on the tool that you'd be using if needed, and of course need to be guided by a policy. Okay. No more questions, so I think we'll be ending right now. As we mentioned, you can always go, I think here we have, I thought we have the email over here, but you can always email me. I'll put the email. If you have any question. We'll be in touch with you and trying to provide you with everything you need. With this, we come to the end of the session. Thank you very much for joining us. And if you have maybe one last question from our side, if you do have any recommendations regarding these webinars for future, about the timing, about the type of topics you prefer, or if you want to recommend speakers as well, just let us know and we'll take it from there. Thank you very much.